We are going to discuss a very important panel discussion. Rather, I would say that the topic title is very interesting. So, that is the global perspectives in the sepsis associated acute kidney injury. Are we speaking the same language? Now, that reflects the need for good alignment in how we are actually approaching sepsis associated AKI in terms of the diagnosis, in terms of timing of the RRT, and also the therapeutic strategies. So these are the headings that we are mostly in our clinical practice get confused, and we are not very sure. So now with this, I would now invite our moderator, Dr. Raj Sekhar Chakrabarti. He is the Director Nephrology and Renal Transplant Services from Jasoda Hospitals, Hyderabad, India. Very renowned nephrologist, researchers from India, part of the Akin group research the section, and we have been like very fortunate to interact many times in India. Now he will be moderating the session, and with this, we will be also having our very good panelists. First one, Dr. Adrian Wong, very dear friend, and he would be also our the mentor for Nephrocritical Care Society. He is the consultant intensive care and anesthesia from King's College Hospital, NHS Foundation, London, UK. Now, I would also invite Professor Dr. Tugan Utku, and he is the professor in the Editave University Medical Faculty, Department of Anesthesiology and Reanimation, Kosciuszko Hospital General ICU, and he is the president of Turkish Society of Intensive Care. So, very happy to have you, Professor Dr. Tugan. Now, I have also the privilege to introduce Dr. Manish R. Balbani. He is the Secretary, Indian Society of Organ Transplantation, consultant nephrologist, and transplant physician from Saraswati Kidney Care Center, Nagpur, India. And last but not the least, the convener of Indian Sepsis Forum, Director, Department of Critical Care and Emergency Medicine, Regency Super Speciality Hospital, Lucknow, India, Dr. Jas Javeri. Very good friend and also dear colleague. Now, with this, I would now invite Dr. Chakrabarti to lead the session.
Yeah, friends, good evening. We have just heard Dr. Ronco elucidate what we know today regarding the sepsis, its pathogenesis, and to some extent what is likely to be tomorrow's scenario as far as the management is concerned. So, with this, let me open this forum. Yeah. To the first question to Dr. Wong. Just a minute. I'm having a power outage here and using the phone to do the same. But
It's raining heavily in
early
Hyderabad.
in Hyderabad, yeah.
Yeah, yeah.
Well, welcome change, yeah. So, Dr. Wong, with the preliminary discussion, whatever we had, most of us face on a day-to-day basis 50% of our patients in the ICU having sepsis either in the initial days or subsequently. Can we open today's discussion by exploring how sepsis leads to the progressive organ dysfunction across systems? What are the key pathophysiological mechanisms at play? Dr. Wong?
Is he there? Yeah. Dr. Wong is there. I think he is muted. Okay. Yeah.
Sorry, my internet connection at work is really bad.
Yeah.
I didn't catch that question.
No problem. Yeah. So, Dr. Chakrabarti, can you please repeat? I think. Yeah, you are muted. You are muted.
Yeah. The question to you, Dr. Wong, is having just heard, is there a echo?
Yes, yes.
It's okay now.
Yeah. Having just heard from Dr. Ronco regarding the pathogenesis and what the future may be looking like for sepsis in our ICU. Many of us face on a day-to-day basis at least 50% of our patients, either in the beginning or subsequently during their stay in the ICU, having a diagnosis of sepsis. Can you please dive into the pathogenesis of sepsis and how it affects different organ systems? What is the key pathological mechanisms at play?
I think if I knew that question, I would be won a Nobel Prize somewhere already. I think classically, if you think about the pathogenesis of sepsis, it's in terms of hemodynamics and hemoperfusion. It's classically defined by vasodilatation. Okay, that's the classic thing we all of us learned in our medical schools, and we've recited that, etc. It's got to do with the inflammatory mediators, and there is, more importantly, in recent months, our individual bodies respond to the pathogen. So work by colleagues looking at genomics, moving Singer groups looking at the mitochondria have gone down that line. If you allow me to just quickly focus on the kidneys as an example, classically we think of perfusion of the kidneys being impaired as part of the sepsis illness process. But equally, we know, as Collier has also said, that these inflammatory mediators might influence the kidneys perfusion directly. And it is not just at a macrocirculatory level. So it's not just the fact that your perfusion pressure is low, but probably at a microcirculatory level, there is abnormal flow perfusion in the kidney. It's difficult to weigh up which is the predominant pathology, because for a variety of different reasons, we tend to focus on macrocirculatory numbers. We can produce a mean arterial pressure, we can give some volume, but what happens at the microcirculation with all these inflammatory mediators is a bit more difficult to ascertain. So I think that's where my interest and where my reading is going to. Can we do something at that level?
As Dr. Wong said, what we understand today, there need not be a decrease in the organ perfusion, but it is in the microcirculation. Sometimes there is called shunting of blood from the capillaries, and therefore the capillary bed is ischemic. This is what we now know as one of the pathophysiology. Yeah.
And I also would also add that actually, even if the microcirculation is normal, the utilization at a cellular level may not be. So there's so many different things that we don't know, which makes it exciting to try and find out and work out.
Yes. The second question to Dr. Utku. Sepsis is not a monolith. We all know now. The sepsis spectrum, which we just heard of. There are intra-abdominal sepsis, thoracic sepsis, urinary, soft tissue, device-related. So can you please enlighten us, how do different sources of infection, for example, intra-abdominal versus thoracic, lead to or influence the clinical outcomes? And is there a different way that we have to approach these patients? Dr. Utku, please.
First of all, I want to express my best wishes and my feelings to everybody. Yes, someone mentioned that is in 1st of May, as you know, is a Labor Day. We are very happy to work in that day as well. And if you concern your question, of course, the sepsis is the main problems in all ICUs in all over the world, and I see more than a couple of hundreds participants in that valuable webinar. And I'm sure that the source of infection differs from the countries to countries and the institution to institutions. It depends on what kind of patients you ordinarily follow up. If you work in a general ICU, you are open to every kind of danger and patients, and most of the patients is at least in the nowadays And it's because of the respiratory infection, and of course, is always is a rule intra-abdominal infections, as you mentioned. And of course, this particular reason of infection sites, it makes differ the all of the story actually is the prognosis, and the is directly affected to the physiopathology, and then may cause some differ organ is insufficiency because of the source of infection. And if you divide in a three separate infection source, let me, if it's possible, it's according to the frequency is faced in clinical practice. First of all is the bloodstream related infections. These are sometimes is directly related to the catheters, for instance, and the blood source infections may affect all the process in a different manner. But if we talk about the intra-abdominal infections, it's a little bit different because intra-abdominal space and the infections cause inflammation inside the abdomen. It may directly affect the renal site as well. But we well know, and I may add some sentence from my dear colleagues, Adrian. Of course, there are some certain pathophysiological process, but it's a little bit chaotic in manner. The things we do or with things we are not to do, it may affect the results. I mean, as a consequences of renal failure or acute kidney injury, that may focus on the that is basically the fluid resuscitation. It is very important points if you accept that the infection source is in the intra-abdominal. So it may a little bit different pathophysiological value may add the clinical scenario. And I may say that if it's the respiratory failure, the respiratory infection may cause some hypoxemia, and hypoxemia may cause some hypoxemic action to the renal phase. That may the main role of the respiratory infection, besides the all infective immunologic reaction. And if it's intra-abdominal infection, it may cause directly is increasing the intra-abdominal pressure, and then may cause some perfusion deficiency onto the renal site, and that could be the other reason. That's my comment on your question. If I hope it will be the answer.
Yeah. Thank you, Dr. Utku. As we discussed, Dr. Wong told us the pathophysiology starts off probably because of either microcirculation being there or the cellular level hypoxia or ischemia. Dr. Utku told us that each type of sepsis has its own way of causing organ dysfunction and also affecting the outcomes. For example, the intra-abdominal sepsis may contribute to various intra-abdominal organ dysfunction by various mechanisms, including increase in the intra-abdominal pressure. Whereas the respiratory infection, hypoxia, could be an early event which is causing organ dysfunction. Let's move on to Dr. Balwani. Can you please shed light on endotoxins and cytokine? In your mind, in the pathogenesis that we just heard, what do you think is more important, or do you think both are important, and can you explain?
So at outset, I would like to thank the organizers, Dr. Tapas, and yourself, sir, for moderating the program. Now, as we all know, it's a complex interaction at the hemodynamic level, in the systemic level, and at the kidney level. So as we understand the more and more of pathogenesis, similarly, we'll have the better approach towards the treatment. So understanding pathogenesis is very important. At the systemic level, sepsis is a pro-inflammatory state, which is driven by the pro-inflammatory cytokines and chemokines, like interleukin 1 beta 6 8. We all know TNF alpha. And this activates the complement system, exacerbating the inflammation, in turn increasing the reactive oxygen species. Along with it, the DAMs, that is damage associated molecular proteins patterns, pathogen associated molecular patterns, TLRs, toll-like receptors, and all these combine and initiate a cascade of inflammatory events. So apart from this, sepsis leads to alteration of renal blood flow, like at the macrovasculature level and at the macrovascular level. So it indirectly and directly leads to ischemia of the kidney. Because of hypoxia and reduced blood flow, it leads to the cellular damage. Apart from this, there is an interesting mechanism which leads to the renal, vascular, and tubular dysfunction. So, at the endothelial level, the cells are damaged and it leads to the increased permeability and in turn the potential vascular leakage. So, there is an inflammatory response and the damage at the tubular level also. The epithelial cells of tubules are also damaged by these inflammatory cytokines and chemokines, and it can lead to cellular apoptosis. So all these three are the main uh, mechanisms which leads to the acute kidney injury. There are certain other newer emerging evidences in terms of gut kidney axis involvement and metabolic reprogramming. So understanding this will help us in better treatment approaches. So that is from my side.
Thank you, Manishji. So we just heard that whatever little we know regarding damage associated molecular substances, very early in the sepsis pathophysiology or pathogenesis, there is a recruitment of cytokines, endotoxins from various organs. And once the organ dysfunction starts, one organ can actually affect the other organ also. With this, let us move on to the next question. Dr. Javeri, you will be the correct person to answer. Fluid therapy remains a cornerstone, but we now understand it's a double-edged sword in a patient in whom you are tackling sepsis and organ dysfunction. Can you quickly summarize for us how would we think about volume status, resuscitation, maintenance, and de-escalation, especially when there is already an acute kidney injury? Thank you.
Thank you, Dr. Rajsekhar, for the wonderful question. Fluid management in sepsis has to be adequate, but this word adequate is very subjective and vague, and it remains dynamic. This is the biggest challenge. We also need to understand that fluid is a drug. Fluid comes with some benefits, it comes with many side effects also. So fluid management in AKI, with or without sepsis, sepsis with or without AKI, has to be personalized and dynamic. We always desire euvolemia, but we understand we have hundreds of hemodynamics tools and we have many parameters for assessment of microperfusion, but there is still no holy grail for diagnosis of the volume status of a patient. So it has to be personalized and dynamic. We have understood through various studies. Few years back when the EGDT paper came, we thought the cutoff should be mathematical, but gradually we understood that it has to be personalized and dynamic. Going to the choice of fluids, especially in context of AKI, starches and gelatins we do not use. Otherwise also they are out of our shelves for last 20 years now. The big fight remains between normal saline, ringer lactate, and other balanced crystalloids. We understand normal saline, especially in large doses, when we give for sepsis resuscitation, can cause hyperchloremic acidosis. So does ringer lactate also cause hyperchloremia and AKI? It is like a chicken or egg situation at times. What is causing what becomes difficult. However, hyperchloremia leads to AKI and it can worsen the renal outcomes. So it has to be prevented. Either we prevent it from the very beginning, we start with a balanced crystalloid, or at least once it starts happening, then at least we should shift to a balanced crystalloid. In absence of major AKI therapeutics till date, we have to have strategies we can prevent AKI or prevent worsening of AKI, and euvolemia and right choice of fluid remains the biggest benefit interventions which can benefit. After balanced crystalloid is albumin. We understand sepsis is an immune dysfunction, and albumin, apart from the colloid properties, it has properties which are immunometabolic reprogramming. It strengthens the glycocalyx. So yes, albumin, especially 4 to 5%, could be utilized for resuscitation in sepsis, and we use it occasionally. Going on to the other part of the question, we tend to have euvolemia, but hypovolemia is big no. Hypervolemia happens. We are over aggressive in the very beginning. We are very keen to resuscitate, but we forget when and how to resuscitate. That is a bigger challenge. So after a day or two of ICU stay, we see patients are bloated up, fluid accumulation syndrome, which can exacerbate AKI. This has to be remembered. Fluid accumulation syndrome will increase mobility, mortality. It can mask AKI, and the renal recovery will be poor. So fluid balance and AKI is like a U-shaped curve. So we have to be somewhere in the in between, in the right sweet spot. Fluid accumulation syndrome also contributes to increased abdominal pressure, and we have heard and will be hearing more from Professor Manu Malbin. How does abdominal compartment syndrome worsens the renal recovery, how it can lead to AKI, and can worsen sepsis also. So we have to follow this model, Rose model for fluid resuscitation. First is resuscitation, then is optimization, then is stabilization, and last is evacuation. So try to have a euvolemic status, but at any cost, we have to avoid hypervolemia in the long run also. Thank you, Dr. Rasik.
Dr. Tugan Utku, the next question, we just discussed intra-abdominal pressure. We know this is a problem, but seldom we check it as a routine. So is there a recommendation from your side in which patient to do it, and should it be a routine measurement, or is there some protocol to do it on the first day of the hospitalization and then a third day or sixth day? Is there anything that you follow, and what is your recommendation? Thank you.
Thank you very much for a question. Actually, we really like to heard about Professor Manu because he's the main expert in that field, and of course, after all, scientific knowledge, most of the ICU units is their own protocols for monitoring the intra-abdominal pressure, and I personally accept the monitoring of intra-abdominal pressure as a component of whole hemodynamic monitoring. So, as a part of hemodynamic monitoring is a different dimension of the monitoring system. It's easy to apply in the bedside in ICU, but unfortunately, from my perspective, in our country, we don't have any sophisticated methods is most widely used for monitoring the intra-abdominal pressure. Rather, we use in an ordinary, let's say, the traditional method to monitor the intra-abdominal pressure. We use the urine catheter for applying the blood pressure monitoring system or fluid field system to monitor the intra-abdominal pressure rather than the centimeter water. And then we monitoring it is a periodically rather than the continuously. That makes a difference because of some consequences of infection. We are always some wonder about the urine infection using that system, and that's why it has to be sterilized method and taken care for that site. If a septic patient is not easily monitored or managed hemodynamically, or if there is some intra-abdominal hypertension in clinically, or in some particular counteracts is during some passive leg rise, for instance, monitoring method, we tends to monitor intra-abdominal pressure. And of course, it's a kind of abdominal surgery, or the surgery may affect the intra-abdominal pressure, have to be monitored intra-abdominally. And after using that method and taking some figures from the intra-abdominal side, it gives us some important early warning system for taking care to decreasing the intra-abdominal pressure, for instance. And maybe the other indications for that, if is a patient, I mean the septic patients and already in ERDS or something, difficult ventilation problems, and it's needed to be prone position, for instance, maybe it's before you do that and after applying the positioning method, it's needed to be monitored into abdominal pressure. So this is the Dr. Yash said that is a course of the clinical scenario is in the hypovolemic side. Of course, it have to be monitoring periodically to be resolved the over fluid or fluid accumulation situation actually. And my method is to check the intra-abdominal pressure at the beginning with using the some, let's say, functional hemodynamic monitoring, giving the fluid resuscitation, because I believe that the fluid resuscitation is only one of the a component of the whole therapeutical approach. And of course, it's very easily applicable in the bedside, and most of the doctors is being tend to give fluids freely. It's another problem, because it's easy to do that, but I believe that it has to be restricted, and it has to be proper evaluated before giving them hemodynamically. I mean, it's needed to be clarified which the component of hemodynamic components is needed to be giving some support. I mean, the vasopressor is very quite often used and other options, and I prefer to use it if it's possible rather than giving fluids. And of course, some maybe I have to be mentioned, and I saw some questions regarding that. In a sepsis campaign, is giving in the very huge of fluid volume, which is very debatable. And I know, at least in my site, I mean in my country, nobody gives 30 ml for kilos. I guess that is the only, maybe the component of the whole, the guideline is not so follow up easily, because everybody knows the overfluid is not so good options. And in this scenario, if you check the intra-abdominal pressure as well during the functional hemodynamic monitoring, so it may a little bit realized how much and how often you have to give fluids, or you have to, when you stop it, or you change your policy to giving another options like in vasopressor or something. And after we able to use vasopressin in our country, because it's very newly is able to use it in a clinical practice because of some official procedures, it's really helped us to protect to renal dysfunction during that all vasopressor therapy and the fluid therapy as well. So we may easily balance, or at least is a better balance to fluid and vasopressors. I may say that it's a intra-abdominal monitoring, pressure monitoring is the main component of the whole hemodynamic monitoring system, and it may affect is directly all the course, I mean all the treatment course, and your choice, and the choosing the therapy and choosing the volume amount of the therapy and etc. That's my comment on the intra-abdominal pressure.
Yeah. Thank you, Dr. Utku. Dr. Wong, one of the most important carry home today would be not just antimicrobials. We have to start it as early as possible, but in some patients, this may not be enough. So what additional strategies, immunomodulation, metabolic resuscitation, adjunctive therapies are emerging in sepsis management? Can you elaborate on that?
I mean, Professor Ronco has already covered a lot of the theoretical side of things. From experience, so just to give a bit of background, I work in King's College Hospital in London. I think when it comes to septic management, we more or less follow international guidelines of fluid resuscitation, early broad spectrum antimicrobials, get the cultures in, and then de-escalate as appropriate. When it comes to the immunomodulatory side of things, it is not routine of what we do. There are lots of evidence out there in terms of using things such as vitamin C, but probably but those we don't do. Probably the one that we are starting to build experience on in King's is the use of extracorporeal support. So things such as a cytosorb. I know Professor Manuel Brain is a big fan of the use of cytosorbs. In King's, we are probably only starting to find our feet for it. We are particularly looking at patients that come to our liver intensive care unit, but also patients who come in from an septic shock. Now, traditionally, the approach has been resuscitate, get the antibiotics in, and then wait. If the patient then doesn't respond, colleagues might consider using the cytosorb. I think the evidence out there is suggestive that if you're going to use it, we probably should be using it at an earlier stage. So I'll be keen to hear the views and thoughts of the other esteemed panelists on this. But when it comes to specific immunomodulatory drugs, we have very little experience of it, at least in my institution.
So I should share with you, India is one of the countries where many of the ICU, we are using filters. It could be for endotoxin, it could be for cytokines, sometimes a combined one like oxyris. And there is definitely some benefit vis-a-vis the hemodynamic improvement. That is, the dose of the inotropes and other things does come down. Though the literature does not talk of any mortality benefit, many of us do, and we have published that there is improvement, and it buys you another couple of days before you are able to do something more specific. So moving on to Dr. Balwani again, can you just quickly tell us about hyperammonemia in sepsis? I believe many of our septic patients do get drowsy. We think of septic encephalopathy as a term. And then when you start measuring ammonia, surprisingly, many of these people have high levels of serum ammonia. What is your take on it? Is there a recommendation to use or check the levels of ammonia in the ICU patients who are septic as a routine? Thank you.
Thank you for that question, sir. So what I understand nowadays, we are seeing that these ammonia levels are usually increased in critically ill patients. Most of the times there is certain liver dysfunction along with the sepsis and kidney involvement. So we should always check for the liver function in such patients, because the sepsis somehow triggers or unmasks the urea cycle disorders. So increase in ammonia can lead to encephalopathy. So that it is very important and crucial to understand and to recognize it in the earlier phase to prevent the neurological complications. So the commonly infections usually trigger those infections which are implicated are the infections from the urea splitting bacteria, and mostly we see it with the urinary tract infections, and those are the complex, that is the obstructive urinary tract symptoms infections. So we should address the underlying liver issue if it is present, and definitely the presence of this higher ammonia levels are associated with the some kind of poor prognosis. To understanding the cause like infection from the urinary tract, complicated urinary tract infections or underlying liver illness may be helping us in the managing such patients, and we need to monitor the ammonia level in such patients, and dialysis also helps in removing the ammonia level in majority of cases. And when we are like in a situation the conventional dialysis cannot be used or the slate is difficult, in those patients SRCRRT definitely helps. So early recognition and monitoring and the treatment of the underlying illness, apart from whenever needed, the supportive therapy with the dialysis or CRRT is beneficial.
Thank you, Manish. So, friends, whenever there is a septic patient who is getting drowsy, please do a level of serum ammonia. As Dr. Manish described, liver failure could be one of the contributing factors, but even in the absence of liver failure, certain urea splitting organisms, infection with them from the gut or urinary tract can have very high levels of ammonia, which can affect the outcomes. And any modality of dialysis does remove ammonia from the body, and the clearance of ammonia depends on the type of dialysis that you are using. But whenever you finish or complete a session of dialysis, the ammonia may have reached a very low level, but in the next couple of hours, again, it will rise. So please do measure and make sure your frequency or your modality of dialysis is also tailored to that. That brings me to the last question, Dr. Javeri. Dr. Ramko did mention about heme adsorption. I am aware there was a consensus meeting in Rome recently talking about heme adsorption being used as a adjuvant in combination with other modalities of dialysis in ICU. Can you just quickly tell us the present understanding of heme adsorption along with the regular modalities of dialysis, their role in the ICU?
Thank you, Dr. Rajsekar. As was illustrated in the first talk, the cytokine cascade is the major culprit in sepsis, which leads to various other cascades and the organ dysfunctions because of cytokine cascade. Now, this cascade has to be cut. The purpose of all heme absorption therapies in sepsis or sepsis with AKI, it could be sepsis or it could be sepsis with AKI, is to cut off this cascade. We need to attain some degree of immunohomeostasis. We cannot obviously normalize the whole immune dysfunction, but this cascade has to be cut. Once this cascade is cut with hemoabsorption or other dual hybrid therapies, the organ dysfunction settles, the PF ratio improves, and the vasopressor requirement gradually comes down. These three benefits are always seen with all the hemoabsorption therapies till date. However, this is difficult to translate into mortality benefit. And what happens with all these adjuvant therapies for sepsis? We fail in big data analytics. The reason is choosing the right endpoints for clinical research. So we have to look at softer endpoints like vasopressor free duration, how soon the PF ratio was coming down, how much was the ICU length of stay? Was there any new organ dysfunction? Or if there was a failing organ like kidney, was it improving with our heme absorption and other extracorporeal therapies? So in this era of evidence-based medicine, we have these therapies have to prove themselves. So far, big data analytics have failed them. However, the experience we have always seen a decrease in PF ratio. We have always seen a gradual weaning of vasopressors and improvement of acidosis and a lesser new organ dysfunction. So we have to look at these parameters instead of looking at 6 month survival or 1 year survival with all this hemabsorption therapy. And the clinical plausibility, as discussed earlier, is huge. The data analytics have again and again failed us, but that should not stop us using them. But we have to use all these therapies very, very judiciously in the right subset of patients. Thank you, Dr.
So, friends, my sincere thanks to all the panelists for throwing light on these very relevant questions for our day-to-day practice in the ICU. All of us are learning how to manage sepsis in the ICU. Each one of us have learned that one, look at your patient on a daily basis or more than once. Look at them early whenever there is an intervention needed. Take specific care regarding starting antibiotics again early. Look at the volume status every day or more than once a day and make sure patient is neither dehydrated nor overhydrated. Then if the conventional things do not work, consider a filter, but please make sure you know what you are doing and there should be enough experience of doing these things, whether it is heme adsorption or a cytokine filter or a endotoxin filter. None of them have had a mortality benefit except in very small data wherein it was used extremely early. So using them routinely is not the correct thing to do, but the main message should go, you please think of your patient in all these compartments and make sure you don't hesitate to change something you prescribed yesterday, but today you may think the patient is hypercatabolic more or the hypercatabolic state has improved. So the key is precision RRT when it comes to the dialysis in the ICU, what modality to whom, when, and don't hesitate to move from one modality to another modality when it warrants. Thank you very much.